Hey everybody, I'm Crystal with Rehab Dynamics Physical Therapy, and today I have Dr. Joey LaMartina with us, who is a orthopedic surgeon at St. Tammany Hospital. So thank you, Dr. LaMartina, for being with us today.
Thank you for having me.
Good. So let's start off with what kind of made you want to be an orthopedic surgeon? What's your journey been like?
Well, for the longest, I've been kind of the oddball in my family. Nobody's really done medicine in my family, so I kind of just been interested in health and that sort of thing growing up, and so I kind of steered toward the whole medicine route from the beginning. And then went to college. Felt like I wanted to go to med school. When I got into med school, the first thing we did was anatomy, and also at the end of my kind of time at Notre Dame, where I went with undergrad, we did a musculoskeletal anatomy class that was purely just all MSK anatomy, and I loved it. Everybody said, don't take that class. It's really hard. It's dreadful. It was like my favorite class in college. So had a really good experience with that. So I really was leaning that direction as I went into med school. And then the first, semester of med school, we did anatomy. I loved it. That was like my favorite class in med school. So I felt like of all the fields, it's kind of, really hit on all kind of different anatomy. Obviously, there's anatomy all over the body, but the MSK stuff was the stuff that really appealed to me the most. And then did a lot of training, athletic stuff growing up, and I just felt like that it all kind of made the most sense to me. So that's kind of the route that steered me toward orthopedics. And then it kind of was really nailed down toward, I guess I would say maybe third, fourth year of med school when I was rotating through orthopedics. I had some good mentors that kind of sold orthopedics to me and basically said it was the greatest field ever. And, I didn't really have a choice after that. So
Got it.
but
And I know y'all do lots of residencies. So what were your residencies focused on?
So I did all my med school at LSU, and then I went to Boston University for orthopedic residency. And, in residency, it's kind of a generalized experience of orthopedics, and every residency is stronger in different areas. Just depends on who you have there. Ours is more trauma heavy. Actually, at the time, I was thinking more doing orthopedic trauma. But I still get to do a lot of fracture work, and we do a lot of that in the community. But this was a little more kind of like level one inner city trauma. But kind of shied away from that after a while and had more interest in sports medicine. I've always been interested in that. So I initially applied into a sports medicine fellowship and interviewed for that. And then in my matching into a sports medicine fellowship, I also had the opportunity and had more of an interest in shoulder as I worked with one of our attendings later on in my residency. And we decided, there was an opportunity to do an extra training in shoulder fellowship. So I applied for that after the fact, and then kind of transitioned from my sports fellowship in San Francisco to my shoulder fellowship in Tampa, where I did, it was more open shoulder arthroplasty based, which is joint replacements, versus the sports fellowship was more arthroscopy and kind of that type of thing.
Very cool. So then what brought you back to Covington?
Well, it's like the old saying, everybody who ever lived here, they always come back. So, but it's just a unique place. Now I've lived in the Midwest. I've lived in the Northeast. I've lived in the Florida. I've lived in San Francisco, the West Coast. I've lived kind of all over, and they're all great. But I'd say that we kind of have a unique community here. It's very different. It's hard to explain to other people who've not been here, but it's definitely, being so close to New Orleans, but yet having our own little kind of bubble here on the North Shore, we're kind of unique. And I haven't really appreciated that everywhere else that I've lived. And so that's the big reason. I have a lot of family here as well, and I grew up here, so I have a lot of emotional reasons to come back as well.
Very cool.
That's kind of what brought me back.
So I said you are working at St. Tammany, but where exactly is your office located?
So our office, the actual address is 71211 Highway 21 in Covington. It's basically on Highway 21, like you're heading up towards St. Tammany Hospital, about a mile before you get to the hospital. It would be on the left-hand side if you got off the interstate heading toward the hospital. We're, just kind of, the closest thing I could think of, there's a Firestone tire place right past if you passed our place, you're going to see that on the left. So we're kind of all in that area that's being developed, the road is widened now and everything else, but that's our office.
Awesome. So what type of patient do you see mostly? I mean, I know you said you have done your fellowship in total shoulders, so I'm guessing shoulders, and what else do you like to do?
Sure. So I see a lot of shoulder and knee complaints are the most of what I see. Taking general call, I do see fractures. We see a lot of hip fractures, obviously. Some of your older patients, you get those. But I see a lot of shoulder complaints more than anything. And then I see a lot of knee complaints, and I see everything up to knee arthritis I do some knee replacements, and I also see everything through shoulder arthritis and people who've had shoulder replacements already. So that's kind of the scope of what I see. I also see kids. I do that more in conjunction with our pediatric orthopedist, Dr. McDaniel, because I did in my sports fellowship, I did a lot of pediatric sports training, and a lot of what she did was more pediatric trauma and spine and whatnot. So she doesn't do a whole lot of arthroscopy. So we work together. So almost any patient that needs an arthroscopic procedure or sports procedure as a kid, we work together and we kind of knock it out. Now, I do see kids kind of starting at around 17 and up. She sees them up to 16. So we kind of overlap in that respect. But so kind of a wide spectrum.
So how would somebody know if they were a candidate for a total shoulder or a knee?
That's a good question. They probably need to see me. No, no. I mean, really, it's hard to really say. Well, do I have bad arthritis in my shoulder? I mean, shoulder replacements. There's two basic types, and they're indicated for different reasons. But if for some reason somebody over the years is losing motion in their shoulder and they're stiffening up and they're feeling a crunching or grinding or clicking or almost a ratcheting in their shoulder, they're most likely going to be somebody who has bad arthritis in their shoulder, who then may be a good candidate for a replacement. Somebody who's had a lot of rotator cuff surgery, for example, that have had failures, or they've become what we call pseudoparalytic and they can't lift their arm up at all because they're just so weak, that's more probably your candidate looking at a reverse shoulder. However, there are scenarios where we use a reverse shoulder for that arthritic patient that we talked about first. And so there's a lot of different ways to apply those implants. So it really would just be, kind of a steady decline. Oftentimes a history of shoulder surgery, sometimes not, especially in the primary arthritic shoulder. But it's just a little bit different pain patterns and something that kind of, we can work through. X-rays do shed a lot of light on that as well.
And as far as like recovery wise, I know you mentioned in both of those surgeries, most of them are for patients that don't have their full range of motion. So after total shoulder, can they expect to get their full motion back?
I would tell you they can expect to get the vast majority of it. It really just depends on how bad off they are to start. Both of those implants, for example, total shoulders in general, if you look at the history in the literature, they generally get a little bit better range of motion than reverses on average. So a reverse shoulder implant, you may expect, to get your forward elevation back up to 110 to 140. I will say anecdotally that a lot of people do get better than that. A reverse shoulder replacement is more constrained. It's designed to be more constrained. So there are some limitations in rotation, reaching down to your side or behind your back, that you tend not to see as much with a total shoulder. However, a total shoulder relies on a full intact rotator cuff, which the reverse doesn't always have to have. So the total shoulder is designed to act more like a normal shoulder, just you're resurfacing and taking out the arthritis. So in theory, yes, the total shoulder should get slightly more motion. It should act a little more like a normal shoulder, but it's really kind of done, you want to do it in the right circumstances, because if you have a really debilitated patient who already has a lot of preoperative weakness, even if they have bad arthritis, they may not respond very well to a total shoulder, because it does require a lot of rotator cuff rehab and getting yourself strong and using it again, whereas the reverse tends to be a little more forgiving.
Got it. And just with a plain rotator cuff patient, do most rotator cuff tears need surgery? Or is that just a general?
That's a good question. So it really depends on the size. It depends on a lot of other patient factors. I would say full thickness rotator cuff tears, as a general rule of thumb, do not heal. But that does not mean that all full thickness rotator cuff tears need surgery. There are a lot of patients with what we call a small tear, for example, which is less than a centimeter, that there is good evidence in the literature that physical therapy is very helpful in getting those patients back to a pain-free shoulder and a good functional shoulder. And in those patients, that we try to not do surgery if we don't have to. However, full thickness tears, about the flip of a coin, may progress. And if they do, those are the cases where you say, okay, well, you've tried some therapy, maybe surgery is indicated for you if you've kind of failed those measures. But you kind of have to think about it from that standpoint. Now, when somebody comes in and they say, well, I fell on my shoulder, I could lift it up yesterday, I can't lift it up today. Those are the patients that, yes, they do need surgery.
Right.
So it's kind of the acute traumatic rotator cuff tear versus your patient who comes in with a degenerative rotator cuff tear where they were fine yesterday and they woke up this morning and they had some soreness in their shoulder and then they have a degenerative cuff tear. So a little bit different. But I would say that it really just depends on the scenario. But yeah, most, if not all, traumatic tears should have surgery. From the flip side of things, most tears are not traumatic. And in those cases, a lot at least should be trialed with therapy before proceeding with a surgery.
And while we're on like not needing technically surgery, a lot of my patients come in that have just had injections. How many injections per year does the research say that a patient could get without it being like harmful to their?
Well, in general, I mean, the way I look at injections is they're not good for your tissues, period. So I kind of say, look, I caution patients about getting them too frequent. I generally don't allow them to get any more than 3 or 4 a year. But I also look at that as, well, it really comes down to, all right, if you're needing an injection every 3 months and you're getting it for shoulder arthritis, well, the shoulder joint is probably pretty bad off. And if you're trying to say, well, I have really bad shoulder arthritis, but I'm not a good medical candidate for surgery, well, then you can get those injections and you could probably have them, 3 times, 4 times a year for the rest of your life.
Right.
But we already know that the condition of the shoulder is pretty poor. But if you're looking at it and you're looking at it from a soft tissue standpoint, and you said, well, there's a reason why your shoulder is hurting more so than just, inflammation. Well, if you continue to just inject, my philosophy is more, well, we're kind of putting a Band-Aid on the issue. Maybe we need to look a little more. Let's look at the MRI. Let's see if there's a reason that we can address with a more durable treatment than just getting an injection. So I try not to exhaust patients with endless injections unless that's kind of their wishes,
Right.
or they're kind of the patient who's just not a good surgical candidate, in which case the best we have to offer is helping symptoms without, modifying anatomy. So.
Right. I know that's a big thing just because, a lot of times they get relief for 6 months to a year, and some of them get relief for not even 24 hours. So it's just
Right.
always like a crapshoot whether, it helps.
I totally agree.
Yeah. And moving on to knees real quick. Is there any conservative treatment that you might do for someone that doesn't necessarily want to do surgery for knee arthritis or degeneration or anything like that?
Yeah, I think that, like, physical therapy is good evidence. There's good evidence behind it with knee pain, with knee arthritis. You tend to run into those patients who start to lose a little bit of their motion with knee arthritis, and in those patients where you can really gain their extension back and kind of try to maintain the motion that they've had, I feel like they tend to do okay. It's actually remarkable, some of the patients who come in with horrible looking knee x-rays and their knee doesn't hurt on that side, or, you're kind of like, how do you explain that? Whereas, you look at some people and they have the littlest bit of knee arthritis and their knee hurts them. But, I try to exhaust all conservative treatments on patients with knee arthritis. I really like the bones, touching the bones, if you're going to consider a replacement. I feel like a lot of people jump the gun and they're like, oh, I just want the replacement. But not necessarily appreciate or understand exactly what they're getting into. It is easy to replace a knee, but at the same time, they're not a perfect, outcome in all cases. 8 out of 10 people really like their total knee. Those are probably the people who are really bone on bone. They've really exhausted everything. So I really try to have those patients try a course of therapy, try your injections, maybe try the viscosupplementation, all those different, which are the gel injections, the rooster comb that everybody talks about.
Mm-hmm.
But you try to just, you try to encourage them to go through those avenues before jumping straight to a total knee. Now, you do see some patients come in, who get frustrated. They may be that they've gained some weight. They're like, I'm just too, I feel like it's too hard for me to work out or exercise or try to cut back, and I just need my knee done because my knee's just getting worse, and they feel like they're chasing their tail. And, that's a tough scenario, but you try to get them to exhaust those things first. And you guys probably see quite a bit of patients with knee arthritis,
Right.
both before and after surgery. So I do advocate for that.
And then as far as the total knees, what kind of surgery are you doing now? Like, I've heard there's lots of new stuff out, like robotics and.
Yeah, so I've gone through the certification for robotics. Where I currently operate, we don't have a robot. They're looking into potentially getting one. They are doing a robot, and the robot is designed basically for cuts, making basically your femur cut, your tibia cut, and so you basically dial it into you basically use a preoperative CT scan where they get a big scan of your knee, and you basically open the knee, and you basically match off those points with a little device they have, a little tracker, and you touch all these different spots in the knee that make it correspond to the preoperative CT scan, and then they put that into this robot, and then the robot says, okay, well, these are the, you kind of decide where you want to make your cuts, and then plug it into the robot, and you just kind of guide the robot in there, and it makes the cuts. There's advantages of the robot, or that it is probably potentially less damaging to the soft tissues. It does add time to the case. So there's more open skin time in most cases. Certainly a learning curve, and so that's kind of like the experience of people who've kind of been using it. We have not used it much at St. Tammany yet. I know they are using it in town. That's kind of a newer thing. Robots in shoulder surgery, to kind of switch back to talking about shoulder surgery, are kind of maybe a few years down the road. Not quite as sure how they're going to apply it yet. The thought is maybe on the preparation of the socket when you're doing total shoulders, but they haven't really figured that out yet. It's definitely a much smaller space to work in the shoulder than it is in somebody's open knee. So I think that some of the thought is that the robot could be a little large and cumbersome as well, because it is kind of a big device. There's not enough data yet to say whether one is better than the other. For years there has been what we call navigation for knee replacements, and that's done through a similar mechanism, but not quite having the robot make the cuts. It's just that you kind of put little markers on the knee, and you basically dial in your cuts based off of that. And that hasn't really been borne out to show any difference in outcomes necessarily in patients. So it kind of has lost favor a little bit. So the robot, although seems like a potentially more promising endeavor, we just don't really have enough data to say it's much better yet.
Got it.
Yeah.
Cool. Well, thank you so much for your time. Is there anything that I missed that makes you such an excellent orthopedic surgein over somebody else? I know you've had a lot of training and stuff in the shoulders.
Yeah, I mean, I think the unique thing, I think the only, there's a lot of great orthopedists around here. We're fortunate to be in an area where we're, I don't want to say overly saturated, but we're somewhat saturated, and that we have a lot of people to offer care. I would just say, the only unique thing that I would say is that, my shoulder fellowship is something that I look at as a unique component to my training. There's a lot of fellowships that do some shoulder replacements here and there, but the shoulder fellowship was basically just, almost all we did was just replacements. And it was very heavy in that. And I trained with some great mentors who are very well known around the world. And they just, really kind of, I learned more. I still say this to this day. I learned more in probably the first one day in the operating room with one of those guys than I learned in my entire year doing shoulder replacements as a sports fellow. Not because they didn't do a good job there. It just was a different mentality, different mindset.
Right.
So there's definitely a difference than from, I do shoulder replacements versus kind of like, but I do a bunch of other stuff versus the guys who do it all the time. And so I learned a lot from those guys. So that part I feel like makes my practice a little bit unique, and my experience, I'd say more than anything, a little bit unique. But otherwise, no, I think there's a lot of great people out there who all do a very good job.
Awesome. So yeah, I think each of you probably specialize in your own thing, and that's kind of what we always look for. Is I want somebody that knows what they're doing for the shoulder, right. And I want somebody, for each different body part. So
yeah, and that's the way medicine is kind of shaping. The days of there's a few good guys out there, still very good generalists who can do just about everything. But the way medicine is changing, the way training is changing, everything is kind of shifting towards a specialty focus within a specialty. So it's it may seem like, well, wouldn't you want to be able to do it all? Yeah, but the people who do the most of everything tend to do it better. So I would say that that's kind of that's kind of the way we're shifting. And the end goal is for better patient care. So.
Got it. And one last thing while I'm thinking about it, shoulders. Do you do elbows, hands too, or mainly?
I do. So I do. I see hand up to neck, or I'm sorry, I see hand up to shoulder. I see a lot of neck pain because a lot of people confuse it with shoulder pain, but that's okay. I try to get them to the right people. But I do see hands. I would tell you, if it's complex hand stuff, I do try to get them to a hand surgeon. We'll occasionally see some carpal tunnels and things like that we take care of. I do see elbow complaints as well. I did do some elbow training in my shoulder fellowship is shoulder elbow, but for about 95 shoulders, you see about 5 elbows are just so much less common. But I see everything from fractures and everything up to the shoulder. So I do treat most of that stuff as well. Again, if there is any thing that I feel like is out of my realm, there is some pretty good overlap with the hand guys, because a lot of the hand guys do hand to elbow, and I kind of do shoulder down to elbow, so we kind of overlap well and can find a nice complement. Because, like I said, we do have some people around who are well trained as well. So
awesome. So if somebody wants to schedule an appointment with you, what number do they call?
So our office number is 985-893-9922. That's to get to the front desk. However, if they're ever somebody that you know, or you want to reach out to me, I can always circumvent that and kind of take care of it myself. So
is there typically a long waiting period to get in to see you?
Not traditionally, not super long. Usually we get patients in with about a week or two at the latest. Sometimes I get them in the next day. It just depends on the day. Things, sometimes there's open spots. We go by a template, and there's established patient visits and new patients, but we can tweak that sometimes as well. So it's usually not an issue. But yeah, we can get patients in pretty quickly.
Perfect.
So it should never be hopefully never an access issue.
Awesome. All right. Well, thank you so much, Dr. LaMartina, for being with us. And y'all feel free to contact him with any questions. Go see him for your shoulders and your knees, and he'll take good care of you.
All right. Thank you.